Okay, Assalamu alaikum. Good evening. Welcome, everybody, and thank you all for joining us today. I hope you will find this day useful and interesting. My name is Rihab, and I'm one of the members of BSAP-CH Steering Committee. For who doesn't know BSAP-CH, it stands for British Sudanese Association of Pediatric and Child Health. It's a non-profit, educational, and charitable organization that was established in 2003, and it had been running a lot of activities in collaboration with SAB, and this Awareness Day is one of them. For more details about BSAP-CH, please visit our website, www.bsapch.co.uk. So let me now give you a quick overview on how today's session will be running. It will be a 2-hour session during which we will cover 3 topics. The first 2 topics will approximately be 25 minutes each, followed by 5 minutes for questions. The third topic will contain 2 parts presented by 2 speakers, a 10-minute introductory part and then a 25-minute talk. For questions, please write them down in the chat box and our moderators will read them out to our speakers. If you're watching us from our Facebook page, please write your questions in the comments and we will try to answer them if we have enough time. If the number of questions exceed the allocated time, you can send your questions to our email together with the speaker's name and we will direct it to him or her and get back to you with the answers. Our email is info@bsapch.co.uk. This Zoom will be running in a webinar-like way, that is, all mics will be kept muted all the time. Please participate through the chat box. So let's make a start. And I think our first speaker is here. So Habab, please.
Thank you, Rihab. Welcome everyone and good evening for you. Great thank you for joining our COVID and Children Awareness Day today. My name is Habab Hassan. I'm SP for Pediatric Training in Oxford Ordinary, and I will be happily moderating part of the session this evening. Thank you again for joining us, and I hope that you will enjoy our company. With great pleasure and honor, I'm going to introduce our first speaker for the day, Dr. Raymond Nethercutt. Dr. Nethercutt is a consultant general pediatrician with a special interest in respiratory conditions at Southwest Acute Hospital in Enniskillen, Northern Ireland. He is also the clinical lead for cross-border interoperability with cooperation and working together, the partnership body that supports delivery of European-funded health and care projects between the health services on both sides of the Irish border. As a former Chief Clinical Information Officer in the Western Health and Social Care Trust, Dr. Nethercutt possesses expertise in the development of improvements in using technology to capture quality, comparable and measurable data, and ways that can be used to improve healthcare outcomes with a more holistic, integrated system that is patient-centered. Dr. Nethercutt is also the current officer for Ireland with the Royal College of Pediatric and Child Health. He is a passionate advocate for children and for improvements to child health outcomes in Northern Ireland. He will be delivering the first talk about the unintended consequences of COVID pandemic on child health programs. As Rihab mentioned, it will be a 25-minute talk, and we will have 5 minutes after that for questions and answers. Please feel free to post your questions into the chat, and we will have a look at it after he finishes talk. Dr. Nethercutt, you are very welcome. The mic is yours.
Thank you, Habib. It's an absolute honor and privilege to be here with you. Assalamu alaikum. It's great to see so many names that I recognise from my work in the Republic of Ireland. I have to give Basil a shout out, Basil El Nazir. We did work together in the Coombe in Dublin many years ago, and it was a time in our lives that we will not remember, we will not forget easily. Look, thank you all very much for the invitation to come and speak with you today. I know that there are some colleagues coming a little bit later that will talk a little bit more of the detail of the infection in terms of its consequences for children. But it's been my experience during this pandemic that children tend to be not very well considered, and that the consequences for this generation of young children and young people is going to be much longer lasting than I believe any of our politicians or our public services or our health services have made adequate preparation for. As was mentioned, I'm currently the Officer for Ireland for the Royal College of Paediatrics and Child Health. That's a role that I've been in for almost 2 years. And it allows me to join with colleagues both in the Republic and also other colleagues throughout the UK and sometimes even into Europe. We'll not use the B word for this afternoon, but it is an absolute privilege to see and to hear how much energy and effort paediatricians and child health professionals are putting into their response to help colleagues in terms of mutual aid, but also to try and guard and prepare for some of the consequences that I want to highlight for you this afternoon. As Habib and Rehab have said, please, if you have any questions, put them into the chat box, and we will spend a few minutes at the end trying to highlight those questions and answer as many of them as possible. So I'm not going to spend terribly long talking about the direct consequences, but we know and we're very thankful that children are not badly affected by the direct infection of COVID. I think when we were anticipating the entry of the virus to Europe and globally, we were very concerned because our experience of respiratory coronaviruses are that they do spread very rapidly and readily in the childhood population. This is not our experience with COVID-19, but long COVID is a feature in children's care and disease, and PIMS TS, and I know colleagues are going to address this a little bit later. One of the first consequences of the infection and the lockdown and the initial responses to the infection for us in paediatrics were that there were a significant number of delayed presentations. So children with diagnoses such as sepsis and DKA, in fact, in looking at child mortality figures in the UK, there were a number of deaths that were attributed to delayed presentations to acute services. Really, that such heightened fear existed within the community that parents felt that hospitals weren't safe places. And we very quickly at a college level and also regionally and nationally put together responses to ensure that it was very clear to parents that if they were worried about their child, that they actually needed to seek help and to seek help early. Thankfully, in the second surge, the delayed presentations haven't been as dramatic as they were in the first phase, but no doubt there are still some concerns among parents for bringing children to our attention. We've also lost quite a bit of our hospital services. The outpatient experience and the ability to see patients face to face is greatly reduced right across the NHS. We've seen quite a number of our paediatric intensive care units in the first wave, and now more so in the second wave, converted into adult intensive cares. Talking to colleagues in paediatric intensive care in London, about a third of their paediatric units have now been handed over wholly to adult care. Now that's not adult intensivists looking after their adult patients in pediatric intensive care estate. It's actually pediatric intensivists, pediatric intensive care nurses looking after adults in their normal business. There's also been a significant reduction in the amount of elective surgery, particularly complex elective surgery for children whereby children would potentially need HDU or ICU for recovery. All that has really had a line drawn under it. And there's also a concern that whenever some of the pressure from this latest surge starts to reduce, that actually our colleagues in pediatric intensive care do need to have a window of rest and recuperation before they can engage with that work. There's been significant loss of real estate for paediatric beds right across east of England, London and the south of England, as far north as Stoke-on-Trent. In Northern Ireland, we have sort of given over some side wards and beds over to adults in terms of nursing and caring for patients with COVID. And the experience we've had is that although we will readily want to help out our colleagues and to make sure that these people get the best possible care, it's sometimes reversing that state and getting back our beds in a timely fashion has been much more of a difficult sort of thing to achieve. There have also been some direct consequences in terms of our child health workforce. So health visiting colleagues in the community have been diverted to adult services, and particularly with the onset of vaccination programs, a lot of our colleagues have been seconded. So healthy child programs, the ability to deliver on statutory visits, and even the ability to deliver some of the immunisation programs for universal services in children has been compromised. By and large, there's been a little bit more cognizance of protecting that service this time around, but certainly in the first wave, the amount of catch-up that needed to occur during the summer was significant, and I don't believe that it is fully complete as yet. Child protection referrals, by and large, have significantly dropped off by a minimum of 10% to sometimes up to a quarter. The normal mechanisms whereby children would come to attention in terms of being present at school, being present at daycare, having regular statutory visits, a lot of those have fallen off. And that is obviously a significant concern for all that are involved in safeguarding and the care of children. And obviously schools, so I realise that some colleagues will be talking a little bit more about that, but educational opportunity play and schools programs, particularly in relation to health, for measurement programs and programs for vaccination, thinking of the human papillomavirus program for teenagers, that has been significantly disrupted and will take some time to recover. In terms of the indirect consequences, this takes a little bit more lateral thinking, but educational progression for children and young people is going to significantly have knock-on effects. So the children and young people who were having exams last year, whether it was GCSEs or A-levels, InterCert or Leaving Cert, are going to have significant questions that will remain very much unanswered in terms of whether their achievement was the same as the year before or even this year's achievements. Are they any less than anybody else's? And that's going to leave a sort of a legacy of anxiety and concern for those children and young people, for their parents. And I think that some of these types of areas of concern need to be addressed directly. Although the governments and the proper authorities are trying their best to mitigate. They aren't really looking beyond the immediate term for this summer's exams to come. I would also suggest that social and emotional development is very much underplayed in terms of children and young people not having the opportunity to mix, not having the opportunity to share time with friends. The face-to-face interaction and play, particularly for younger children, is absolutely vital in terms of their ability to understand the boundaries of social development. And you know, there's only so much that you can get that from your direct family, and only so much that you can get for that from online. Those are things that are useful, but they don't replace that ability or that you know, experience of playing with peers in a physical open environment. My experience broadly is that the COVID has really accelerated and you know, grown the number of adult priorities whenever it comes to the allocation of resources. Now, I'm not saying that it's not appropriate to respond to this current crisis, but every other day in the media, there are people talking about the waiting lists for adult services, which were bad before, and they've got worse. But when it comes to the ability to provide resources for adult services and the ability to provide resources for paediatric and child health services, there needs to be some parity. And I believe that that is going to be very difficult to achieve. I also believe that it's going to be very difficult to deliver on such things as sláinte care, some of the broader policy directives whereby more care would be delivered in the community. The hospital services, particularly for adult services, have grown very significantly in esteem, and the long-term sustainability for services in terms of prevention and protection, particularly when we think about child health programs, are going to, I believe, need to have some time and energy to address the deficits there. Pediatric training is and has suffered. The ST1s and possibly the ST2s in this last year don't really know what bronchiolitis looks like. Now, that may be a good thing for some of us who are much longer in the tooth, but certainly for our trainees coming up, not knowing how to manage and to deal with and recognise bronchiolitis, whether it's RSV, metapneumovirus, adenovirus, or whatever, the absence of bronchiolitis and the level of bronchiolitis that we usually get at this time of the year is something that they haven't seen and will need to make up for at some stage in the future. There have also been paediatric trainees that have been, particularly junior levels, seconded into adult services. And again, that's going to have to be addressed. One of my particular concerns is actually that of GP training. So most of the GP trainees that do spend time in paediatric services, gaining very valuable experience, skills, and knowledge in managing common childhood ailments, are going to miss out both last year and this year, because most of those GP trainees have been seconded back into adult services, and they're often the first types of trainees that get brought back into adult services to aid in the COVID effort. No doubt people will have seen headlines in the news and the gaps in social and economic deprivation are and have increased. When Many of the politicians were talking about this initially. They were describing COVID as a leveler of, of experience, but subsequent experience has been shown that that's actually quite the opposite. It is the poor, it is those who are older, it is those who are socio and economically deprived that are suffering much more in terms of their experience of morbidity and in fact mortality. And that growing gap of deprivation is being accelerated by lack of educational opportunity, particularly for those families who don't have the means to provide decent internet connections and decent technology for their children to access some of the school curriculum. There's also some consideration that needs to be given to mental health. I know as a college, we have particular concerns that the anxieties, the amount of self-harm, the amount of eating disorders are all on the increase. And we know already that our colleagues in child and adolescent mental health services are already inundated, and we will need an integrated, coordinated response to try and respond to this and to provide some sort of strategic and tactical responses for children and young people, so that we can mitigate against some of the worst effects. There will be a return to normality, and the reason I put it in inverted sort of commas there is that we actually don't know what our normality will be like. If you notice, I did put the pandemic starting in 2019, but there is really a question about the end date. Although we will see an end to the surges, and that we do have vaccines that we believe will be effective, our normality, our ability to hug one another and our ability to socially connect has been very significantly impacted, and the response to how we return to normality and what happens next needs to be very carefully considered. And in my view, there needs to be a very significant prioritization given to children and young people, because they have suffered considerably and it hasn't been well enough recognized or responded to. The economic prospects globally are quite gloomy in terms of the outlook, in terms of the ability to get back to normal business and production. The costs, the direct costs that we know about and the indirect costs that we haven't been able to calculate yet are going to go into the multiple trillions of dollars. And that cost may well be spread out over quite some time. But who's going to bear that cost? It's actually going to be the children and young people of this current generation. That rebuilding of economies needs children and young people to become the adults of tomorrow, to be self-sufficient, to be resilient, to be able to be productive within their own communities, to be able to run businesses, to deliver services, and to pay taxes. That's going to be a significant challenge if we have directly compromised their ability to get good quality education, and if we've directly undermined the confidence even in the assessment processes that these children have had to work through. The resources available for public services, I'm fairly confident that health will get a top slice of the resource allocation, and particularly public health in terms of responding to this crisis. But many other public services are going to suffer economic hardship, particularly schools and education. I think are going to go into further decline and have further difficulty in terms of addressing the needs for the future. And that really all amounts to careers and jobs for the upcoming generation. There has been mass unemployment, certainly within the Western economies. And it will be difficult to make sure that that's redressed. And families and family structure have taken a hit. Again, we're coming back to mental health. The experience of domestic violence, addiction, and crime, those things have all changed very significantly, and they have become even further hidden within our societies, and will need to have a very well thought through response, especially whenever it comes to considering children. Not that I want to leave everybody in doom and gloom. Every cloud has a silver lining, and I believe that there are some very significant opportunities going forward for child health and for children. So children, by and large, are extremely adaptable. They thrive and they survive despite many of the adversities that they face. If we give them half a chance, if we support them as best we possibly can, children will thrive, they will adapt, they will surprise us with their ingenuity, their creativity, and their innovation. But we need to expect that from them, we need to encourage them, and we need to prepare the ground so that that becomes a reality. The use of technology in this current pandemic has accelerated, and by and large it has been a success. And the reshaping of our services, certainly as a college, our ability to influence in particular NHS England, Scotland, and even in Wales, the college's cooperation and ability to influence the people that are shaping services has been much more than we've had in the past. And we're very hopeful that as services start to be reshaped and restored, that we will have the potential for better services that are potentially more streamlined, but potentially much more effective for the future. Vaccination development will never be the same. And the efforts and the energy that was put into paralleling the normal, very long process of vaccine development was very much accelerated. And I don't think that will be lost on the ability to deliver vaccination. And as we all know, as pediatricians, the vaccination and immunization programs worldwide are the number one lifesaver and the number one sort of intervention that provides for children a huge health advantage going forward. There's also been a very clear need for better data for children, and that again we've convinced many governments and agencies that they need to do more, and they should be doing more in collecting better child health data and using that child health data to improve services. Levels of cooperation and responding to need have been much better during this pandemic than they've ever been before. And it has been a huge learning opportunity, and it is something that we can maximize on so that going forward we can ensure that we do the best for our children in whichever communities and whichever parts of the world we find ourselves working. Look, thank you all very much for your time. I believe I'm just coming up to 25 minutes, and we'll
thank you very much.
5 minutes for
thank
questions.
You for such concise and interesting presentation. We have really enjoyed it. Going back to the chat, I can see one question from Nahla Abbas. She said, will Dr. Nethercott advocate COVID vaccination for children school age, particularly 16 to 18 years old?
Absolutely. I believe that for So the reason why I put a query on whether or not this pandemic is going to stretch and last longer beyond 2021 is that unless we achieve herd immunity within populations, we are not going to be able to get adequate control of the virus. And children, although children aren't badly affected by the disease and the virus itself, there is the potential that children could become a reservoir carrier. And I think that, or believe that, the vaccination programs do need to stretch into the young people community, in terms of particularly those children going to secondary schools, age 11, 12 and up. And it should almost certainly by the end of this year be coming into primary schools as well. There are a number of safety studies that have been commenced. So the initial studies didn't include very large numbers of children, but those safety studies to ensure that the vaccine all the vaccines are going to be safe for children are currently underway, and we expect that many of those will be reporting by the end of the summer.
Okay, thank you. There's another question from Fatima Badawi. She said there is a big impact on children. They stay at home, not playing at yards, and rather spend more time on social media with very unhealthy lifestyle. So what to do for them as compensation for this at home?
I'd say that many people will have many responses and will have much advice to give. I suppose my main advice would be that it's really important to find a way to bring children out into the fresh air in a socially distanced way, in a way that's going to be acceptable to them. But children really do need to experience and get experience of physical activity in the outdoors. Now, in many environments, that's going to be more difficult in terms of particularly large urban centres. But particularly the younger children aren't at significant risk, and transmissibility, particularly for younger children, is not high. So I think it's vital that parents and that we as health professionals encourage parents to, as far as possible, to provide opportunities for regular exercise for children, at least 3, if not 5 times a week.
Okay, thank you. And then I think this will be the last questions from Haytham Mustafa. He says, thanks for the great talk, Dr. Nethercutt. What do you think the new normal will look like for pediatric services, especially in terms of OPDs, outpatient departments? More virtual clinics?
Yeah, I think virtual clinics have a huge amount to offer. I have been running a virtual clinic for my asthma service over the last number of months, and many of the patients and their parents enjoy it. The telephone clinics, I don't believe are very good quality communication. As a pediatrician, I miss seeing children. And if I can see them on a video and I can interact with them and play with them by video, that makes my day. And I think that the future, we will return to face-to-face clinics. Face-to-face clinics are absolutely going to be part of our offering for the future. But I think that in terms of reviews, and that we will have a mixed economy of video clinics and all the benefits that they bring with our face-to-face clinics, and that we have the potential then to deliver much higher quality services and interaction with children and young people and their parents.
There's only one question left and 1 minute left. Question from Abul Qasim. He is asking any difference regarding virus virulence between hot and cold weathers?
I know that some of our colleagues that are coming later in the day have more expertise in terms of infectious diseases. So it may well be a question that we better recycled for a little bit later. But we do know our experience of this summer was that it was much quieter. On the flip side of that, and again, maybe it can come out in conversation a little bit later, is the Australian experience of RSV has had a very significant resurgence during the Australian summer. So the Australian summer has seen a huge amount of RSV bronchiolitis that was displaced from winter to summer. I'm not sure if that's going to be the same for the UK and for the rest of Western Europe, but it is a concern because although paediatric services haven't been massively busy, we are actually all very fatigued, and that fatigue is not there. We will need some recovery from that, and I'm not sure exactly when that space is going to be.
Okay. Thank you very much. There are still 2 questions, but we will be happy to email it to you later on. Please,
Perfect,
everyone
thank you.
is welcome just to write to the PS ABCH email, and then we will redirect the emails to Dr. Nethergott. Dr. Nethergott, allow me to say very thank you. We are really grateful for your contribution today by the name of British Sudanese Association of Pediatric and Child Health and Sudanese Association of Pediatricians. We are really grateful for your contribution today, and thank you for such a great talk.
Well, thank you so much for the opportunity, and I wish you all the very best for the rest of the afternoon. Unfortunately, I have to go to the ward for handover. Thank you.
Thank you very much, Dr. Nethergott. And Habab, I think we can go to the next speaker. Hani, are you ready? Bahari, please unmute Hani and Habab.
Yes, I'm here.
Unmute Habab, please.
هاتي بدون تميل بدون تاني نقطع ممكن يكون كحاني.
Okay, seems like Habab might be having technical issues. So I will introduce our next speaker. This presentation was prepared by Dr. Carmen Gonzalez. She's a consultant in pediatrics, infectious disease, and immunology, trained in Spain, worked in Malawi for many years before moving to the UK, currently working at Sheffield Children's Hospital. Due to unforeseen circumstances, Dr. Gonzalez couldn't be with us today, and she sends her apologies. Her presentation will be presented by Hani Ahmed Gouey. Dr. Hani is a pediatric registrar working in infectious disease department at Sheffield Children's Hospital together with Dr. Gonzalez. He's a University of Jazeera graduate, started his pediatric training in Sudan, then moved to Saudi Arabia before finally moving to the UK to continue his training. Hani, please, the mic is yours.
Can you see my screen?
Yes, Hani, go ahead.
Okay. Assalamu alaikum. It's my pleasure to be here today presenting a short talk about just a short overview about PIMS-TS or MISC. This talk was originally supposed to be presented by one of my consultants, Dr. Carmen Gonzalez, but she unfortunately couldn't be with us today. So I will try and be up to the standard and present it. Shall we start with a short question, just as a something to flavor? You saw a miserable child who is a 2-year-old with fever for 1 week, red eyes, skin rash, and swollen erythematous fingers. What would be your diagnosis? Measles, Kawasaki disease, toxic shock, scarlet fever, or sepsis? Can you please choose your answers? I'll give you 10 to 15 seconds. There should be a poll that is popping onto your screen. If you can choose the answer and submit. Do we have a result for the poll? Okay, exactly what I expected. The majority of people chose Kawasaki disease, which is not an answer and is not unsurprising. If you ask me this question, I will ask you, when did this child present? If this child presented before the COVID pandemic time, then the answer may be different. If you tell me this child presented after the COVID pandemic time, then the answer could also be different. Because now we are just, the way we think about this kind of presentation is a little bit different, and this is the talk we are going to talk about today. So the whole thing about PIMS-TS started during the first wave of the pandemic in Southeast London in April 2020, when people were in the middle of the lockdown, a lot of cases were being reported in pediatrics and in adult services together. London has seen the highest number of cases in the whole UK. In London, there were a series of admissions to intensive care units, pediatric intensive care units, within a short period of time between the 17th and the 25th of April. They were really critically unwell children. And eventually, we came to know that these children had PIMS-DS or were treated as PIMS-DS later on. And based on the observation made during that time and at Evelina, it based the whole thing for the PIMS-DS, and it was the first reported cases there. And then subsequently, international centers and international hospitals started recognizing this and started reporting it. So a lot of case reports started coming out after the London announcement. In Spain, in America, in different parts of the world, they all reported similar presentation of those children, similar kind of morbidity, and people started questioning what is happening. This is one of the publications that was first made. This is probably, these are the first children who presented in London. And this, I appreciate that the writing might not be very clear, and this slide is really a busy one with very small print, but it essentially says that these children presented with kind of similar characteristics together. They were really unwell children. They all had high inflammatory markers. They came all in a procoagulant stage, so they had high fibrinogen level, high D dimers, and they also, some of them presented with features related to Kawasaki disease or looks like Kawasaki disease. Some of them presented in cardiac failure or with cardiac compromise, had high troponin, had high pro-BNP, which are markers for, myocardial dysfunction. And then Whitaker also reported in July a similar kind of cases. He reported 58 children. One of them only died, and 2 of them required ECMO. Also, with a broad spectrum of presentation coming from febrile children with inflammatory presentation, going to severe shock needing intensive care. Almost all of these children had persistent prolonged fever. They all had neutrophilia, lymphopenia. They had high inflammatory markers, CRP, ferritin, and they all were having a high procoagulant state. The kids who presented in shock had high troponin and high pro-BNP. Those presenting with Kawasaki disease features, plus or minus cardiac involvement and shock. Also, some of them had coronary aneurysms, and the majority of them also had the other features of Kawasaki disease, not necessarily fulfilling the full criteria to diagnose Kawasaki disease, but they had some features of it. Another paper came out in June. This is probably the largest cohort of reported cases so far, 95 cases presented in this publication. 4 cases of them only were suspected, the rest of them were considered diagnosed as PIMS-DS. 80% of those children required intensive care. 2 of them died, and all of them were having things in common, which is high inflammatory markers, procoagulant state, and some of them also had cardiac dysfunction. As you can see from this table, the majority of patients presented with mucocutaneous or skin kind of manifestations. The rest of them presented in different systematic presentations. So they can present with abdominal symptoms, diarrhea, vomiting, abdominal pain. Kawasaki is similar kind of presentation with red eyes, skin rashes, lymphadenopathy, and and a small percentage of them presented in cardiac failure, or let's say in shock. And when you do an echo on them, you can see clearly there is myocardial dysfunction. A small minority presented with neurologic features, some of them stroke, some of them, encephalopathy type of illness, headaches, meningitis-like presentation. The conclusion, or let's say the thing that was common between all these publications, between all these case reports, was that we are dealing with a wide spectrum of disease that are all presenting with high inflammatory markers, CRP, ferritin. They were all having a procoagulant state, high D dimers. Some of them were presenting in shock, and those ones had high troponin and high proBNP. The patients who were really unwell and sick were the ones who had, the acute myocardial injury, and those who had coronary aneurysms. And obviously, this is something that also presents in Kawasaki disease. Some of them also had coagulopathy, so they can present, and it can be either a hypercoagulable state, or it can be the opposite one. So like similar DIC picture. As you could tell, this disease or this condition is so far affecting all the systems in the body. The usual presentation of thinking that COVID only presents with cough and COVID pneumonia isn't true about this. I'm just going to skip this to the next one. The WHO then made a definition and criteria of diagnosis at that for young people, which is, temperature for 3 days or more, plus some criteria having rash, shock, features of myocardial dysfunction, coagulopathy, or presenting in the abdominal kind of presentation, elevated inflammatory markers. And when you investigate them, you can't find anything else, no evidence of sepsis, no evidence of toxic shock syndrome, and you find an evidence related to COVID. So these children, if you ask in history, they will tell you one of their parents had COVID in the last 4 to 5 weeks, or they were in a school where they had to isolate because someone in their class or a teacher in the school that they have been in contact with was COVID positive. So you can see that in history. It's not necessarily that they will present with a positive PCR test, but the majority of them also can present with positive serology, as in you test for COVID antibodies and you find that positive. So having a PCR negative for COVID does not exclude it. Having a COVID serology negative for antibodies also doesn't exclude it. If you suspect it, you need to act on that. Why does it happen? Still, people are studying this, but what we know for sure, until now, is it's not an acute kind of presentation. It doesn't happen immediately when you get the virus. Actually, most of these children were completely asymptomatic until they presented with the syndrome. They all had contact with a parent at home, or a school teacher, or a nursery, or a preschool teacher who was positive COVID. And then 3 to 5 weeks after being exposed to the virus, they present with this hyperinflammatory presentation. People talk about cytokine storm, and a lot of this has been speculated from adult studies and studies related to HLH in adults. Essentially, COVID, the virus itself, when it goes in as any other organism or any other foreign body, it stimulates your immune system and stimulates your inflammatory markers. If you get a virus inside, your body will start reacting trying to contain the infection. This is usually followed by the immune system trying to make an adaptive response. So T cell, B cells, and other inflammatory cells will get attracted and start to be stimulated. The major stimulants and cytokines involved are the interleukin 6 and tumor necrosis factor alpha and interleukin 2. Usually, if you have an infection, this kind of response, the body will contain it after some time, so it doesn't go on to become something that is not controlled. In PIMS-TS patients, this goes on to become an uncontrolled hyperinflammatory cytokine storm, and this will affect your systems. So multiple inflammatory responses in all systems, including endothelial injury, causing the hypercoagulable state, death in cells in different parts of the body. This is why if you take as a biopsy from a heart of a PIMS-TS patient, you can't find any virus in it, but the heart muscle is affected by the response, by the hyperinflammatory response that happened because of the virus. How do we treat this? I'm going to put another poll. A 6-year-old child presented with fever for 6 days and abdominal pain with normal examination, no clear focus for infection. What do you think you're going to do? Sepsis workup plus antibiotics, oral antibiotics and discharge? Do you think this is PIMS-TS, so you do the workup and keep them in for observation? Full workup plus, start immunoglobulins, admit for observation. Can you please choose your answer? (10 to 15 seconds before we get responses. Results, please.
So 59% of participants casted their vote. Here's the results. You should be able to see it.
Okay, sepsis workup and antibiotics is the majority. No one is going to discharge this child. That is really nice. PIMS-TS workup and watch. Full workup plus IVIG 15% and admit for observation 11%. Again, if this child presented before the COVID pandemic, probably your response would have been different. But because this child is presenting during the COVID pandemic time, your response again will be different than the first one. So the evidence, there isn't much evidence. You are all aware that this is all new to everyone, including those who made some kind of consensus or tried to make some guidelines. People try to extrapolate as much as we can from adult practice and adult studies. The recovery trial is a major thing that is still going on here, and people are getting recruited to that. So you get recruited, getting IVIG, steroids, or standard treatment. The major thing about PIMS-TS is switching off the inflammatory response, the hyperinflammatory response. And that's why they call it immune modulation rather than immune suppression. You are not suppressing the immunity, although you are doing that, but you are modulating the response to get it back to the normal track. So immunoglobulins is the first line of treatment. If that doesn't work, some hospitals give a second dose of IVIG and then move to steroids, but it depends again on the case, and it depends on the severity of the illness, how bad the child looks, and some people just prefer to go from IVIG directly to steroids if that isn't responding. Biological treatment like tocilizumab, infliximab, and anakinra is third choice if no response to the above ones. But above all of this, we should not be forgetting that these kids need supportive treatment to run aside to the immunomodulatory treatment. So fluid management.
Sorry, Hannah, to interrupt. Just 5 minutes left.
Yeah, fluid management is really a big thing, especially for those who are having myocardial dysfunction. That's why they are needing intensive care. Even giving immunoglobulins to those with cardiac dysfunction has to be given carefully because IVIG itself can affect the heart function. And then people have to agree within an area or within the region on how we deal with severe cases, how we transfer them, who's going to take them if they have really bad cardiac involvement, which intensive care units are going to take them, what guidelines do we do, who to contact. So some stuff are non-clinical, but they are as important as the clinical stuff. The Delphi consensus came out almost in August this year, sorry, last year, and they just tried to give some broader approach or broad guideline on how to treat these kids. And they all agreed on we need to give them all immunoglobulins. The dose has been agreed. People who have, kids who have been treated in the first wave in April received different doses of steroids to the doses we are giving now. They received really higher doses and everything. Now this has been modulated again to become the least dose that can have the desired effect. So again, IVIG, steroids as a second line. We need to be sure that these kids are having anticoagulation treatment given. If we're giving steroids or aspirin to that, then we need to make sure that we have gastric protection. If the one and second line are not, the first and second line are not making any difference, then we need to go to the immunomodulation third line. And during all this time, it's very difficult to predict how kids are going to go. The majority of them in our hospital have improved and got discharged. We did not have any losses so far. And I think in the last 4 or 5 months, only one child needed to go to the third line. The antithrombosis is an important aspect of it and is also again extrapolated from adult studies because those kids have got hyper or let's say procoagulant state, so they are liable to have a thromboembolic event or thromboembolic phenomena. So that's why all of them, if they have D-dimers that is higher than 5 times of the upper limit of normal, and that is different between hospitals because different hospitals use different kind of units and measures, then they need to be on low molecular weight heparin subcutaneously. You have to be careful. Some of these kids will present with low platelets and they will have low fibrinogen, and actually giving them aspirin and heparin might increase their risk of bleeding. So you have to be careful on who to give what and when to give that. Last thing I want to mention, this is my last slide actually, is if you don't know what you are dealing with, you better treat it as suspected because these kids really deteriorate quickly, and if you don't get on top of their inflammatory response, they can really be in a bad condition. So you shouldn't be waiting for diagnosis or anything. If you suspect it, you just need to treat it. Thank you.
Thank you, Hani. Thank you for such interesting and concise presentation. Screening through the chat, Ali is asking what is the right answer for the poll question.
There isn't a right answer. The poll question was meant to stimulate us to think that before the COVID pandemic, a child who is presenting with such a picture, we would have treated them as if they are in sepsis or they are septic children. We will do the normal thinking about looking for the cause, looking for the evidence, looking for the evidence of infection anywhere, doing all the viral studies, all the bacterial cultures and everything. And sometimes we have discharged and treated kids before for temperature of unknown origin, and until they became well, we didn't know what we treated them for. But right now, because we're dealing in the COVID pandemic, it's a little bit different. So there isn't a model answer. I just put them to stimulate the thinking about the difference between now and then.
Yeah, okay. Then Sarah Al-Amin is asking what are the complications to PIMS and how fatal is this syndrome?
The complications are probably could be part of the presentation itself. So the complications are similar. If you are presenting with a Kawasaki-like illness, then the complications are similar to those in Kawasaki, which are cardiac dysfunction, coronary aneurysms. That's why when they present on admission, they need to have an echocardiography and exactly look for coronary artery measures and Z scores. Also, having a procoagulant state can put you into the risk of getting thromboembolic phenomena. So you can have a stroke, you can have TVT, you can have pulmonary embolisms, although we haven't seen as much of that. And the other thing is you can have multi-system failure, and that by itself is a complication of it. But these kids just need intensive care, proper treatment, and they usually get back to normal within less than 2 weeks if they are really lucky.
Okay, and then we have a question from Safa Ahmed. She said, thank you very much, Dr. Hani, for an informative and comprehensive presentation. In our country, the limited resource settings, can you stress the most important investigations and simplest treatment?
That is a very difficult question. In the recent SAP conference, Dr. Thana presented experience from Dr. Jafar ibn Auf Hospital, and she presented the cases that presented and how they treated them, how many losses they have, and all that. I'm aware that doing all these investigations isn't probably feasible in governmental hospitals, and patients have to pay for that. The only thing I will say is all these patients, especially in our tropical area, will need to be covered by broad spectrum antibiotics because we don't know what that is. I'm not sure the availability of ICU beds. I know probably there are less than 10 beds in the whole country for pediatrics. So covering with antibiotics, if there is no intensive care bed, then probably they will need multidisciplinary involvement. If there is an infectious disease consultant need to be involved, rheumatology team are actually the leading teams on this, and immunology. If there are investigations to be done that helps you with follow-up, it's actually the inflammatory markers. If you can do only the CRP every day until this patient goes home, that can help you deal with it. But also don't forget, you need to know their coagulable state. So the D-dimer is also crucial here. So if you can do D-dimers, CRP, full blood count, fair enough. If you can cover them with antibiotics and start the treatment with IVIG and steroids, hopefully that will take them through.
Okay, we have a lot of questions in the chat box and only we have 2 minutes. So I will go quickly through the chat. Muhammad Amin is saying that he had a patient who just responded to IV antibiotics and not requiring IVIG. I think he means when to give intravenous immunoglobulin.
If we don't know what we are dealing with and patients are not responding. So if you admitted a child with 6 like the kid we have in the poll, a child with 6 days of temperature, you admitted them, you continued monitoring them, they still continue to have temperature despite being on antibiotic for more than 72 hours. You investigated, you couldn't put your finger on, the focus of infection. What are you waiting for? Because having a negative COVID test, as I said, and waiting for antibody tests to come isn't going to help that child. I think they should just go to the immunoglobulins directly. But if they responded, that's good. Then that is not PIMS TS.
Okay. Then I think this will be our last question, and then I will hand over to May. Sahar is saying, can we say that COVID-19 has good prognosis in children?
Prognosis as in long term, if you are talking long term. So we know that most kids don't get acutely unwell as bad as adults, and not as many of them as adults. But because I'm working in a tertiary hospital, I see the worst of it. I see only the bad ones that get referred from DGH hospitals and all that. So on the long run, if you don't develop the complications, like the coronary artery aneurysms, and these can sometimes be irreversible, then you might get away of this. Also, if you develop stroke because of thromboembolic phenomena, then you might have to live with the consequences of that. But otherwise, the inflammatory response itself can be contained, and I think they can go back to their normal lives. Yeah, the majority of them will be okay.
Thank you, Hani. By this, we came to the end of the session of the PIMS, for Pediatric Inflammatory Multi System Syndrome. Thank you, Hani, for your generous contribution and nice presentation. Now I will hand over to May, and for the rest of the questions we haven't answered, please write it down and send it to our emails. I have sent it earlier in the chat box. We will direct all the questions to Hani, and he will kindly respond as soon as possible. Thank you very much.
Thank you very much, Habab. Can everybody hear me?
Yes, we can.
Yeah, so now it is our time to hear another exciting topic about care of young population and children during COVID era and reopening of school. This topic will be delivered in 2 parts. The first one will be presented by Mrs. Hala Abdulrahim. Mrs. Hala is a graduate of Al Ahfad University, Family Science. She was the head of the Department of Nutrition in Ibn Sina for 13 years. Now she is the head of School Health Program in Health Promotion Department, Ministry of Federal Health, Sudan. Welcome ever so much, Mrs. Hala. Will you just mind if I keep your headset just 2 minutes before the end of your topic? The mic is yours.
Okay. Hello. Hello, everyone.
We can hear you, Mrs. Hala. Go ahead.
Okay. Hello. School health program. Sorry, I can't change the slide. Next. Next. Definition of school health. All activities and service provided in school and with collaboration with them to promote the student and worker health, either physical, psychological, and socially. Next. School health goals, capacity building, the educational focal person in the school health, raising the health awareness among the school community, such as teacher, student, etc. Nutrition status, prevention from communicable and non-communicable disease. Next. Medical examination for student, early detection, advocated and promote the accept physical activity in school from healthy body, providing curative services and health care in school, improving the health of the school environment. Next. Student, oh, sorry, I lost my, no. Sorry, I lost my slides. Okay. Student, school age children make up more than quarter of the population in Sudan. The school years are the years of growth and development from student. Therefore, they must have complete health care in order to ensure their healthy growth. School-age children are more likely to suffer from communicable disease. Next. Next. Sorry. Next. This large sector affects negatively and positively on health in the community and can be used to support health program in the community so that the benefit is widespread. So students campaign this large number in school may pose significant risk and increase the severity of disease unless a healthy environment is provided, raising the health awareness of students and educating them about the health uh, concept that contribute directly to the health of society. Next, school component, school health services, health education, school environmental health, school nutrition, psychological health, physical education, community participation, promote employees' health. Next, school health services. School is the most suitable place to provide health services because the students stay 8 hours per day for 9 months for a year. These services include medical examination from class 1, class 4, and class 7 in the primary school, and class 2 in secondary schools. Next. School health, education, school feeding, school mental health, physical education, and recreation, care for children with the special need. Next. First, procedure referral to the nearest health center, keeping the medical register of the student. There are many services provided in health center or hospital, such as immunization and vaccination program against epidemic and non-epidemic disease. Next, oral and dental health care, eyes and nose care, emergency care for students, referral to the highest and specialized level of cases, follow-up of chronic disease, diabetes, hypertension, asthma, etc. Laboratory tests, urine, stool, blood, or for hemoglobin and blood type. Next. School, it is It is a most suitable place to provide and receive health services. The teacher who is trained in school health activity will be responsible for their implementation. However, there are some activities that can be carried outside the school, such as medical examination of new students in the fourth and seventh graduate and the second grade of secondary school. This is based as the nearest health unit of the school. Consequently, the coordination process is integrated between the school and nearby health unit. This also require training health services. Next, this also requires training health services framework and provider on the principle and application of medical screening to students so that therapeutic activity are carried out as planned in the school health register for student and health unit covered by health insurance. Services are linked all the student and school staff. Next.
Mrs. Haller, 2 minutes left, please.
Okay. What is the role of the school health teacher in implementation? Planning for school activity inside and outside the school. Help the guide student in understanding key health issue. Promoting the atmosphere of communication and social work in school, family, and community. Role model assistant guidance and intervention when needed, supervising students while publishing information and fact and conveying health message to their families. Next, supervising students with publication information and the fact and conveying health message to their families and communities. Coordination and cooperation with management and teacher in the implementation of project and activity. Help students modify their behavior and think to face problem in scientific manner. Next. Precaution condition to provide in school during corona. Introduction, corona disease caused by the new coronavirus COVID-19, which lead to many morbidity and mortality cases all over the world and Sudan. It is transmitted through spray with mass direct transmission from person to person. We saw it is very important to change the lifestyle and to implement several prevention measures for prevention, such as washing hands, using sterilized, wearing masks, and physical spacing. The epidemiology situation in Sudan unstable, and the number of suspect and infected and deaths likely between increase and decrease, and the situation virus from state to state, making enhance to choosing and health requirement necessary in any event that lead to gathering people in one place, such as the presence of students in school. Federal Minister of Health recommended to apply and implement health choose to avoid the infection and stop the transmission of the virus to others. Next. The school team must fill the form about the symptoms, especially those have chronic disease, immune disease, elderly. The need for health staff trained on detection of cases, screening, and isolation. Keep social distance not less than 1 meter between each student and the other. Wearing a fabric mask in daily basis. in the case of suspected cases of corona disease, as a school, isolation measure should be taken. Next, health education, distance between the student. Next, the commitment of student, teacher, staff, and support staff to wash hands in the right way and to train and supervise. Consequent provision of water and soap in toilet and hand washing area is mandatory for every school. Provision of toilet and napkins in the toilet and in classroom, entrance and exit of each school, providing sufficient drinking water, avoid the sharing cup, provision of mineral water if it is possible. Next, social distance between, next, social distance between students. Next, this health precaution developed on the base of protocol and guideline by the General Department of Therapeutic Medicine and Quality and the School Health Department of the Department of Health Promotion of Federal Minister of Health, and according to WHO guideline for school during the corona epidemic. This next, this is posters made in school health promotion department and will distribute to the school. Thank you.
Thank you very much, Mrs. Hala. Thank you ever so much for this informative and valuable, instructive talk. Now, will you allow me to introduce the presenter of the second half of our topic, and that would be Dr. Sarah Abdul-Jalil. Dr. Sarah is a pediatric consultant, an NHS Associate Professor, St. George, Grenada, with special interest in ID, immunology, and allergy. She graduated from University of Khartoum, Lord Kitchener Al-Baghdadi Prizes. Dr. Sarah is a fellow of the RCPCH. She obtained her master in tropical pediatric and child health from Liverpool School of Tropical Medicine with John Hay Prize. She was the president of SDU UK in the time between 2017 to 2020. Sarah worked with street children in Brazil, refugee children in UK, and involved in several projects linked to child safeguarding, quality improvement, safety and governance in Sudan. She is a member of COVID-19 Technical Working Group Africa CDC and was nominated to Top 100 Influential Women by BBC in 2019. Much welcome, Dr. Sarah. Allow me to alert you about 5 minutes just before the end of your talk, if that's okay. The mic is all yours. You're welcome.
Thank you very much. Please let me know if you can't hear me or you can't see the slides. And I would like to start by as well congratulating SAP for the successful conference under the leadership of Safa Abdelhamid and the whole team, and for this integrated presentation, and today was really brilliant. My name is Sarah Abdel-Jalil, and I'm going to discuss the reopening of school during COVID-19. Obviously, this is very timely as the plan now to reopen schools in the Khartoum state from Monday, the 1st of February. And there is obviously a lot of planning going behind the scene. And we understand that so far the community transmission rate has dropped, and therefore it is safe to reopen schools. The COVID-19 pandemic has demonstrated the importance of global fight, and what we see today is a global fight. So we have the RCPCH, the Federal Ministry of Health, and different pediatricians from all over the world working together and sharing information. But it highlights as well the importance of those countries who have spent money on the science and research that had made a difference for people to understand the pandemic and to start about producing vaccines. It highlighted the inequalities in health, not only in low resource setting, but even in Europe and in the United States of America, and as well issues about social justice that have been mentioned earlier by Ray. But at the moment, I think we're all watching for the vaccine development and the vaccine distribution, and that what will happen and how will that be equally distributed. When we come and talk about children and young people, and just going through all these points because they have been mentioned before, that the effect of COVID-19 was mainly on children and young people, we can say there has been an invisible effect that is just being now noticed. And one of it is the outbreak of malnutrition in several countries like Sierra Leone, where they have noted an increase of presentation for children with malnutrition due to the lockdown and due to the financial crisis, as a lot of families lost their income. As well, COVID-19 has interrupted the screening and the support programs and vaccination programs in some countries and macronutrient programs. And sadly, there has been an increase in domestic violence and child protection. And therefore, it's important to, we were hoping to have someone from the Social Development Ministry, وحدة حماية الطفل, because this is really important. Due to the fact of the lockdown, there has been an interruption in the mental health assessment, but as well, there has been an increase of anxiety. You can imagine. I think all of us in this call, we have lost someone that is dear, someone we know, a colleague, a friend, a relative, and we can imagine the effect that that will affect children and young people, but as well the fear about the COVID-19 and the misinformation. And as well, there has been a talk about the delayed presentation for other illnesses. I would like to as well highlight that there is a very good story by the UNICEF, Batalati Anti, which address the fears and the anxieties of children and young people about this story so that they understand better about COVID-19. And I find that story is very useful. There is a lot of effort has been done about reestablishing the vaccine, the vaccination campaigns. And these are one of the texts that have been going out for parents so that they will be more confident with the vaccination during COVID-19. I think that was sent about 48 or 72 hours ago. No. We come on to talk about education, as this has been affected as well by the COVID pandemic. And there has been different documents by the UNICEF, by the WHO, and as well by the Ministry of Education. But I would like as well to point the COVID guidelines for educational setting by the African Union, Africa CDC, and it's in Arabic. It has been useful, very useful. I think the main three questions that we will try to answer later is how likely are children to catch and transmit the virus in school setting? What are the most important measures to prevent and spread the infection in school, and when should school close or open? And I think our interest as pediatrician comes from the fact that we are unique and we like holistic approach when we are dealing with children and young people. I'm sure you agree with me. So the integrated model is the most important model between health education and social development at the level of the state, at the national level, the federal level, but at the level of the states and the level of the local government, al-mahalliyat as well. And then the next part will be an integrated model between school team and families, majalis al-ummahat wal-aba, because that's really important. And addressing the children and young people, understanding and their role in fighting the spread of the virus, as well as to try to prevent any anxiety and the worry that the COVID-19 is a stigma or any misinformation, and obviously bullying if they are, for example, wearing a mask, and there will be peer pressure. So COVID-19 has definitely gave an example about learning together, and that we have to share sort of information and good examples and negative experiences. And it is important to understand, first of all, that the community transmission stage is important to decide whether a school will open or remain closed. And there will be a national strategy or protocol. So we understand now that the national strategy is to reopen schools. either complete or partial closure. The movement now is towards the blended education, and we will come and talk about the challenges about digital access. But there has been a lot of innovative methods. And actually, I've learned a lot of these methods by training in workshops from the Ministry of Education in Kassala, because they have created a platform for parents and for children from simple social media platforms. The other way was to prepare hard copies and to use the TV and the radio. And I can see that when people were talking about TV and radio, some people were like, we don't think that's an appropriate way to teach children. But I remember when I was in secondary school, I used to sit and watch Ustaz Mahdi Allah yarhamu, giving lectures about lessons about chemistry. And actually radio and TV may be very useful, obviously, if there is electricity and things are going smoothly. But the other way about opening schools because of the huge number of students is to think about the alternative days. So you have classes that attend 3 days and others another 3 days, and as well curriculum adjustment. So you cannot deliver the whole curriculum in this situation, and there has to be modification. The preparation is important, and it is the responsibility of health and education, not only education, and having a checklist about the human resources within the school. So when we're talking about teachers, we're talking about cleaners, and we're talking about the children, and making sure that everybody understand what is the case definition of COVID-19 and how to self-report and when to isolate and for how long, and when to come to school to make sure that there is an assessment that has been completed over the phone to make sure that really that child is ready or that staff member is ready to come back to school. It is an important period as well about health promotion, so that children who have got complex need or problems, they should have their medication, they have been in touch with their doctors to make sure that there is no risk so that they can come to school. The asthma, having all of their medication, do they have a low immune response? So this process is very important on its own. In this initiative, which is called Aman, and there has been several initiatives and organization. As I said, we looked at the Federal Ministry of Education protocol and guideline, as well as the Federal Ministry of Health, and looked at the 15 steps that have been provided by the CDC. At the beginning, I thought that's too much, but actually with the discussion of teachers and colleagues doctors, it was very clear that people already have thought about these 15 steps and tried to modify the school environment. Then the reality check, which is very important. It is easy to write a protocol, but it is important to check what is available and what is not available. Simple example is, how will children get water without, with protecting the physical distancing? And this example that we have used is the teacher will use a jug and then give the children water in their place rather than they moving to go to get water themselves, and that may cause a lot of issues. But the reality check about what is available in each school is different. So there is a concept about walking the steps, so having the school and class and thinking about the entrance, the exit, the ventilation, the space, the number of the children, whether it's inside the school, whether they're going to split them, so some will be in the yard, whether we can have a gel, whether we can have water, or there is no water, the soup, what will happen. So the reality check and walking the steps is an important concept, not only for the teacher, but for the teacher and the children as well. And one of the main challenges was the physical distancing and how to keep that. So planning the journey. And the main worry is you don't want the school to be a gathering place. You don't want parents and everybody to be gathering there. So actually that will be a negative impact of opening school. As well, the other challenge was the hygiene hub, about having water and soap, and using the posters from the Ministry of Health. So the communication with the Ministry of Health to get these posters for free and to put them across to encourage children and young people so that they can be cooperative and planning the breaks for meals and water, as we have said. One of the useful campaigns was the community mobilization, where there was a local production of facial masks and distributing them. And That is very important because actually the cost of facial mask, it can be very significant. Then having the protocol about who should use them and how to get rid of them and when to clean them, and are they disposable or not disposable. And there, as if you can remember, when the COVID-19 started, people were talking about don't use the mask, don't use facial mask. That was early in 2020. But now things have changed. And I think COVID-19 have showed us the journey of learning. So we have been learning along with this virus, a lot of information. And now the mask is different. So wearing the mask will be mandatory for secondary schools and for the teachers unless there is a clear contraindication. While in primary school, between the age of 5 and 12, they should wear it under supervision. And under supervision is very important. But under the age of 5 years, it's not recommended. And as the talks before, the rate of transmission is very low. And those with special needs as well, it will not be safe to wear the face mask, and maybe it's useful to wear the facial shields. I must say I disagree with Winston Churchill. I don't think there is anything good about a crisis of COVID-19, but I would like to change his quotation by saying, never let a good chance during a crisis go to waste. And the good chance is about the digital access. There's a lot of money that have been allocated for COVID-19, and there's a lot of training packages in Google and other sort of software. And there has to be a pressure about improving digital access if we are thinking that COVID-19 will stay with us for a long time, and there should be a better access for children and young people and families. But obviously, we have to be careful about the online security. Now, the most important facts about what's happening in school, it has been collected from Europe and from America. And so some of these facts may not apply, but we will see. So generally, we understand that closing school should be the last resort, and that we know children, when they are infected, they are asymptomatic, and if they have the illness, it's mild, apart from the cases that Hani has spoke about. And that the young children and preschool do not contribute to the transmission, and the transmission is higher among the secondary school. But now there are talks about the transmission of dirty hands among younger age group, and the impact of closure of school that will have on the physical, the mental, and educational impact has been, people have not thought about it because they were worried about the virus and the death among adults. However, it is very important to understand that if we apply good measures in a school, so if a school have applied very good measures, but in the community there are no good measures to reduce the transmission, it will be very difficult to protect the children when they go back to school. So you cannot just protect them at school. As soon as they leave the schoolyard, they are mixing. That will not be helpful. The other important factor that is very important about educational staff. So the teachers we are reopening schools, the teachers are going, what are the risks for the teachers? Now they are mixing with students and with parents. There has to be very sort of close monitoring for these measures. But however, no data so far to indicate that there is an increased risk for teachers. But obviously, between brackets, that's when measurements have been applied. There was some allegation that when schools opened in 2020, that was one of the reasons for the second wave to take place. But actually, that's not the case. When the schools were reopened late summer 2020, at the same time, there was a relaxation of other measures about physical distancing, about wearing facial mask, about, people thought that's it, that's the end of the COVID-19. And actually, these factors are more important than opening school. And therefore, we have to go back to the basics about the main measurements is about physical distancing, wearing the mask, self-reporting, isolating. Obviously, we have issues with testing. Not all the countries can do testing widely, and therefore we cannot apply this in this situation. So I'm just coming to the end of the talk by, I'm sure you have watched the inauguration in on 20th of January, that there is always a light and there is a hope. And we're thinking, yes, the vaccine is there. We understand better about the virus now. We know who are the high risk patients. And you think, okay, things will be better. And then you come and listen to the WHO and they say, oh, COVID-19 herd immunity will not be achieved in 2020. And that brings you back to feeling, grim and really very low. But we have to think about three areas that I would like to highlight. One of them is data collection. And there's a lot of information that has been mentioned in this conference in the last few days. So data collection is important so that there will be a model that fits Sudan and that we know what is happening among children and young people. Vaccination, we need to understand how will that be distributed and what does it mean. And the third, which is about the oxygen in Africa and the oxygen supply and the long-term solution. And I'm pleased that I will be part of a program about writing some sort of plans about oxygenation and monitoring in Africa. I would like to again thank you for this opportunity and for the valuable discussion. And I will end the talk here.
Thank you very much, Dr. Sarah, for such a precious and informative talk. We still get some time, but yeah, we'll make use of it, starting up our and speaking out our questions. So far, we've got one question. I'll start with it until the others will follow. That's about statistics of COVID-19 in pediatrics in Sudan.
So, what is the question exactly?
So it was just mentioned that way, really. There's statistics of COVID-19 in pediatrics in Sudan. I assume it's about, if you have an idea, what are the statistics so far about the COVID amongst pediatrics population?
Yeah. I think I've watched the talk by Thana, and Thana is here with us, so she can better speak about the cases that she has reported from Jafar ibn Auf. And she will be in a better situation, I think, to answer that question.
Great. And Mrs. Haller, she unmuted. Do you mind, Dr. Bahari, just to unmute Mrs. Haller for us, please?
Okay, just a second.
Thank you.
I'm not sure if she's with us anymore, but I would suggest that we can email the question to her, and when she responds to us, we'll make it available for everyone.
Yeah, exactly. So I assume questions are going to follow now, but even if you pick up your head later with some questions, whoever's there from the audience, you can just feel free to email it straight away, and we will direct it to the speaker, if that's okay. Another question is following: is there any expectation of cases in vaccination or exception of cases in vaccination?
I think so far for the vaccination obviously are directed for mainly adults, and hopefully will be for young people. The exception, I think, for the Pfizer was mainly about whether there was a direct anaphylaxis, especially food allergies, but this as well has been looked at, and it is very, very small, category that will now be offered other vaccination like Oxford, and there's other vaccination that has been approved.
Thank you very much, Sarah. I assume that's an information from Usman Ali to everyone. I would like to emphasize that teachers are not higher risk of getting COVID compared to the generals if protective measures in schools are taken. Thank you very much. There's another message from Prof. Zain. Thanks and congratulations for an exciting and useful symposium. Greetings to all contributors and attending colleagues. Thank you very much. That's from Safa Mohammed. Yeah, I assume she's also telling us information that there's no enough data so far from other hospitals. So far, Jaffa Ibn Auf documented its cases. Yeah, I assume that's it so far. Thank you very much, Dr. Stara. Thank you very much for all presenters, and I'll hand the mic to Rehab. Thank you.
Okay, thank you everybody. Thanks to all the speakers and all the participants. And I hope everybody found this useful and informative. Please, we have dropped a link for a feedback for this session. Please try to fill it up as this is very important for us. And just before we call it a day, I'd just like to, with this current lockdown and home learning, children are spending a lot of time at home. And if you're looking for something creative and fun to do, encourage your children, please, to participate in our art competition. And what I would like to emphasize on is that all children from all over the world are welcome to participate from UK, Ireland, Sudan, KSA, Qatar, everywhere. Please check the details on our website, and I will leave you now with these few slides. If I think Bahari has already shared them, and please again uh, fill the feedback for us. Bahari, please, can you share the slides or the posters for the art competition? Yes, Bahari. So please, while you are watching, you can fill up also the feedback form. Someone is saying feedback form is not working. Is that correct for everybody? Can you please drop me a message in the chat box so that I can know? Were you able to access the feedback form? The new one is working. Okay. So there's a new one which was dropped in the chat box. So please click on that one. Okay, working. People are saying working. Roxana, there's another link. Press on the second link. So again, thank you very much, everybody, and hope to see you soon in more activities. And I think we will just call it a day. So goodbye. I would just like to add something because still people are saying that they did not receive the feedback form. We will send it by email to everyone. So if you couldn't fill it up now, please check your emails and fill it up for us. Thank you.